Hi everybody, welcome to Dr. Manny's YouTube Learnshops. This is part 5 of temporary cardiac pacing. And this is for you guys, any healthcare provider who may come in contact with temporary cardiac pacemakers. And what we review here are the endpoints. Frequently asked questions about temporary pacing, especially transcutaneous pacing, and then review some of the case scenarios that you can interact with. Let's do our last knowledge review. The intrinsic cardiac rhythm refers to which of the following statements? A, B, C, or is it D? The correct answer is A, the patient's own heart rhythm. Which of the following statements explains the relative refractory period, also known as the vulnerable period, which is located in the final component of the T wave? Is it the vulnerable period? Is it in the T wave? Yeah. Is it partial ventricular repolarization? Yeah. Is it all of the above? Yeah, it is. Which of the following relate to the RMT phenomenon? Is it A, B, C, or D? It's D. It relates to all of them. Which of the following best describe the millivolt? Is it A? Is it B? Is it the unit of measurement that quantifies the pacemaker rate? Is it none of the above? The correct answer is it's the unit which measures the amplitude on the ECG, or how big it is. Which of the following connects asynchronous pacing to the atria? Is it single chamber atrial pacing? Only the atria can be paced. Is it mode AOO, or is it all of the above? It's all of the above. Which of the following best explains demand mode pacing then? Is it A? Is it B? Is it C, or is it D? The correct answer is it's A. Atrial pacing will only occur if the heart rate falls below the set pacemaker rate. AV sequential pacing, atrial ventricular sequence pacing, is best explained by which of the following? It's similar to the intrinsic pacemaker activity. The atria are depolarized first and then the ventricles. The atrial systole is prior to ventricular systole, or is it all of the above? AV sequential pacing is all of the above. Which of the following statements is true? Is it A, B, C, or D? The correct answer is D. Which of the following is the intrinsic cardiac pacemaker? Well, that would have to be the SA node. Which of the following does the P wave represent? That would have to be atrial depolarization. What's this rhythm? What's this pacemaker rhythm? This is atrial pacing, AOO, or possibly AAI. Can you name this pacemaker mode? This is ventricular pacing, either VOO or VVI. Can you name this pacemaker mode? Well, this is AV sequential pacing, which could be DDD, VAT, DVI, DDI, and more. So these are some frequently asked questions that I've encountered over my career. Is it necessary to wear rubber gloves when handling exposed pacing wires? The answer is yes. Failure to do so could result in microelectrocution from your static electricity and therefore cause a potential R on T phenomenon, which could result in ventricular fibrillation. What is transthoracic resistance, TTR? Well, this is the resistance that's created by the skin to protect you from outside things. In this situation, we're talking about electrical current flow or electrocution. And this is often associated with transcutaneous pacing. You have to take into consideration the transthoracic resistance in order to provide transcutaneous pacing, because the skin will attempt to resist the flow of current into your body. Does TTR, transthoracic resistance, affect pacemaker current delivery to the heart? The answer is yes, but only for transcutaneous pacing, because the skin creates transthoracic resistance. How long can a patient be paced transcutaneously? Well, theoretically, indefinitely. However, transcutaneous pacing is really only intended to be a temporary therapeutic intervention because it's painful. I mean, remember, you're making the skeletal muscles contract as well as making the myocardium contract. So, the shorter the period of time, the better. In addition to that, you'll develop something called tachyphylaxis, where the skin will increase the transthoracic resistance and make it harder for pacing to occur. So, the shorter the better. Is it normal for muscles to twitch with transcutaneous pacing? We're talking about the chest muscles. And the answer is yes. Transcutaneous pacing stimulates the skeletal muscles on your chest as well as the cardiac muscles, your myocardium. So yes, you'll see a twitching and the patient will probably not be happy. Can muscle twitching occur with invasive pacing, not just transcutaneous pacing? The answer is yes, especially when the current returns to the pulse generator via a transthoracic skin epicardial or epicardic pacing wire, often seen post-cardiac surgery, open chest surgery or heart surgery. Does twitching mean capture of the myocardium has occurred? No. It just means that skeletal muscle stimulation has occurred. It doesn't mean capture has occurred. Capture is determined by whether there's a pulse, a cardiac output, a blood pressure. Does electrical capture mean there's a cardiac output? The answer is no. Just because you see an ECG doesn't mean there's going to be a cardiac output. So you've got to determine if there's a pulse, because you can have an ECG or a pacemaker rhythm that doesn't provide a cardiac output. This is called pulseless electrical activity, PEA, and this requires CPR. Does electrical capture with TCP, transcutaneous pacing, resemble the electrical capture associated with invasive pacing? The answer is no. The ECG with electrical capture with transcutaneous pacing is typically very large, very wide, because it's influenced by depolarizing skeletal muscle, which will make things bigger on your ECG. Can antiperspirant be used in preparation of sweaty skin prior to commencing transcutaneous pacing? And the answer is definitely not. Why? Because it may increase transthoracic resistance, because it creates a barrier. It's better to get a towel and wipe the sweaty skin and dry it before putting your pads in place. Can big transcutaneous pacing pads, which you may refer to as adult, be cut to size for pediatric patients. And big transcutaneous pacing pads are not just for adults. They can be for adolescents or bigger pediatric patients, as you'll see. So, can transcutaneous pacing pads be cut to size for pediatric patients if you don't have pediatric pads? The answer is no. Modification of any kind may alter the current delivery or stop them from working effectively at all. And the last thing you want to do is burn the patient as well. Can big transcutaneous pacing pads be used for pediatrics if there are no pediatric pads available? The answer is yes. Big pads should not be used routinely, however, for pediatric patients, but in an emergency situation, it may become necessary. Code blue. Patient requires pacing. No pads available that are appropriate size. Large, better than nothing. What size transcutaneous pads are used for an adult or for a pediatric patient? Well, it's not really for adult or pediatric. It's basically big pads are typically recommended for patients weighing more than 15 kilos. Small pads are typically recommended for patients weighing less than 15 kilograms. Is it necessary to check stimulation and sensing thresholds every day? The answer is yes. The thresholds should be checked every 12 hours, not just daily, and also if there's a change in the patient condition. Most important is to check the stimulation threshold. Sensing thresholds can probably be done once a day or every second day or every third day according to your protocol. But stimulation thresholds are very, very important. Sensing thresholds are just as important, but they should be checked regularly, frequently, at least once a shift if you work in a hospital, and if there's a change in the patient's condition. Let's look at some case scenarios and see if you can identify what the problem is. You've got VVI pacing, which is probably the most common mode of pacing in temporary pacing. We're not talking about permanent pacing, we're talking about temporary pacing. The rate is set at 75 pulsations per minute, the output 4 milliamps and the sensitivity 3 millivolts. Look at the ECG. There's no problem here. This is normal VVI pacing. Ventricular pacing, ventricular sensing, and if there's a response, it will be to inhibit pacing. Here we have VVI pacing. The rate is 75 pulsations per minute. Output 4 milliamps, sensitivity 3 millivolts. Suddenly, this happens. Your monitoring alarm goes off. They go into a bradycardia. This bradycardia is about 20 to 30 ventricular responses. The main cardiac output systole. It's very slow. They're hemodynamically unstable. Is anything wrong? Yes. What's wrong in relation to the pacemaker? I can't see any pacemaker activity. So this is pacemaker failure, for whatever the reason. This is AAI pacing. The rate, 100 pulsations per minute, output 3 milliamps, sensitivity 4 millivolts. It looks okay. Pacemaker spike. P wave created. Normal conduction through to the ventricles. There's no problem here. This is normal AAI pacing. Then you've got VVI pacing again. Rate 75, output 3 milliamps, sensitivity 3 millivolts, and suddenly their alarm goes off and they go into this rhythm. Well, this rhythm is incompatible with life, which was probably why they started temporary pacing in the first place. But what's happened from a pacing point of view? The problem is pacemaker failure. You will have already commenced CPR, called a code blue, and so on. And someone will be troubleshooting the pacemaker to see why. Maybe the battery failed. Maybe it became disconnected. VVI pacing again, because VVI pacing is the most common mode that is employed in temporary pacing. Rate 75 pulsations per minute, output 2 milliamps, sensitivity 3 millivolts. They suddenly do this. Well, essentially they're in asystole. There's no pacemaker activity at all. What happened? Well, we don't know. But is there a problem? Yes, there is. This is pacemaker failure again. Code blue called. Activate the rapid response team. Start doing CPR. Have someone troubleshoot why the pacemaker has turned off or failed. VVI pacing again. Most common mode used in temporary pacing. Single chamber. The rate 75 pulsations per minute, output 4 milliamps, sensitivity 3 millivolts, and then you notice something is different. We're still in VVI pacing, still at a rate of about 75 pulsations per minute, but we have this beat here, and we have this beat here, which is the inherent beat of the patient. Is there a problem? There's no problem at all. This is normal VVI pacing and sensing. So what the pacemaker has done, it has now inhibited ventricular pacing because it sensed ventricular activity and inhibited stop pacing for that beat. It kept looking and looking for another beat, but didn't find one following that, so it started pacing again. 2 paced beats, 3, 4, then on the 5th one, it determined that there was another inherent beat there at a rate faster than 75 pulsations per minute. So it inhibited pacing. This is normal. VVI pacing, again, rate 75, output 4, sensitivity 8 millivolts. That's a bit high. Well, in actual fact, it's a bit low. Remember, sensitivity, numeric, is inverse to what it actually is, meaning that if you've got a high numeric like 8 millivolts, the sensitivity is low. If you've got a low numeric, let's say 2, 3, sensitivity is higher. So let's see this happens. You look at the rhythm and you see something's wrong. You think. You've got VVI pacing, which is normal, but then you've got this beat and this beat where the pacemaker spike is in the ST segment T wave, which is incorrect. You've got a normal inherent beat there, which means the pacemaker should have turned off. It didn't turn off. So therefore, is there a problem? Yeah, there is a problem, and the problem is failure to sense the intrinsic beat, which could result in R on T phenomenon if it hits the relative refractory period, which could result in ventricular fibrillation. So you probably need to review your sensing threshold and make it sensitivity higher by decreasing the numeric value to less than 8. VVI pacing again. Rate 75 pulsations per minute. Output's low, good, but you're still getting capture. Sensitivity relatively normal or typical. They go into this rhythm. It's a bradycardia. In actual fact, It's a bradycardia, which is complete heart block with an idioventricular escape rhythm. But you don't need to know that. You just need to know there's no pacemaker activity. This may have been the initial reason why pacemaker was commenced temporarily and the patient's hemodynamically unstable. There's a problem. The pacemaker has failed for some reason. It could be that the output now is a little bit low. So here, an output 1 is a little bit low. So therefore, automatically you would increase the output and see if you got capture. And typically it would probably resolve. And you would resolve, you would do your stimulation threshold again. Okay, that's the end of part 5. That's the end of the temporary cardiac pacing Learnshop. And now, if you found this of any value, please forward it to your colleagues and you review some of the other Learnshops. Thanks again. See you at another time.